Well, first of all, we would like to acknowledge the kind invitation of the organizing committee to participate in this meeting. Actually, only 2 years ago, we attended to a meeting like this one with families and scientists, aiming to find some help to study the hemostatic features of patients with CDG. And we get it. We found help from families and from medical doctors and also for scientists like Professor Jacken. So with all this help and with the strong work of Eugenia, who has been working very hard in that field and has already defended her thesis this year, we have obtained some data that we can understand a little bit more the hemostatic feature of these patients. So what we are going to do is just to introduce a little bit the hemostatic system, and later on we are going to show you the data we have obtained in these 2 years. And first of all, I would like to introduce you why we have a hemostatic system. And actually, for human beings like us, the circulatory system is excellent to distribute cells and glucose and hormones and everything to all cells of the organism. But it has a really limitation, a really important limitation, that is the fatal consequences that can be caused by the vascular damage. I mean, the bleeding can cause the death in organisms having a circulatory system like this one. So for more than 400 million of years, we have developed an hemostatic system that respond to the vascular damage, trying to avoid bleeding. And to do that, we have this system has to have a strong response and a quick response, and it has been obtained with few elements, only with platelets and with a few proteins that are present in plasma. So when the endothelium is damaged, platelets adhere to the endothelium, activates and aggregates, and forming the platelet plaque, and in parallel, the procoagulant surfaces are able to activate the clotting cascade, leading to the formation of thrombin, the last serine protease, that finally transform the fibrinogen into the fibrin. So the fibrin clot and the platelet plaque form the hemostatic plaque that avoid bleeding. And obviously, this strong response has to be restricted in time and space. Only when the vascular damage appear, the hemostatic system should respond. So the hemostatic system should be also controlled, and together with procoagulant actors, we need anticoagulant elements and profibrinolytic elements. So, and this slide shows the coagulation cascade, and you can see in green all procoagulant elements leading to the formation of thrombin and fibrin. And recent evidences show that factor 11 is an emerging element as a procoagulant element, really relevant for the hemostatic system. But we also have anticoagulant elements, and you can see here in yellow. And the best one, no, the main one is antithrombin, because it inhibits different procoagulant proteases, but mainly thrombin. And you can also see here the elements that degrade the fibrin clot. So the hemostatic system is an equilibrium between procoagulants and anticoagulant elements. And with this kind of equilibrium, you can understand that even minor modification affecting both procoagulants or anticoagulant elements could have pathological consequences. And we can find people with thrombosis, but also people with bleeding. And the best example, for example, is if you have a deficiency of antithrombin and a strong anticoagulant, you have a high risk of thrombosis. But on the other side, if you have, for example, a factor 11 deficiency, you have a bleeding tendency. You have C hemophilia. So what happened in patients with congenital disorders of glycosylation and concerning the hemostatic system? When we have few data, like for all rare diseases. But thanks to God, I mean, this paper from Dr. Morava appears this year and has a review of a lot of patients, a lot of data that are being published on this issue. And obviously, this paper detected that the hemostatic system is severely impaired in patients with congenital disorders of glycosylation, the main one, the PMM2 CDG disorder. And actually, you can see that several anticoagulant elements, antithrombin, mainly antithrombin, but also protein C and protein S, are significantly affected, and many patients have deficiency of these anticoagulants. But on the other side, and this is something that is surprising, also procoagulant elements seems to be affected, and as you can see here, mainly factor 11 is also affected, is also deficient in many patients with CDG. We have also evaluated few number of patients, 12 PMM2 CDG patients, but we have studied more details of these molecules, particularly of antithrombin and factor 11. And according to our data, all patients have antithrombin deficiency, and this is the main the average of antithrombin levels in patients, in our patients. As you can see here, they have a strong antithrombin deficiency, only 35% of the normal levels that we can find in healthy subjects. And we also detected a significant deficiency of factor 11. So with this picture, we have an important question to answer. If we have affected anticoagulant, but also procoagulant in these patients, what's the final status of the hemostatic system in this patient? Or in other words, they have more prothrombotic tendency or they have more pro-hemorrhagic tendency. Maybe we had more data, we can answer that question, and we can have a look to the global hemostatic test that can allow us to know how the hemostatic system responds in these patients. But unfortunately, there are few data available in the literature. In this paper, they say that obviously different tests evaluating the time to form the clot, like the APTT or the PT, are prolonged, and we have confirmed this data in our patients. So these parameters suggest a pro-hemorrhagic tendency, a pro-hemorrhagic status in these patients. And Maria Eugenia has already evaluated new tests that evaluate the global hemostasia that are more sensitive and can give us more information about this. For example, the thromboelastography, and you can see here we have compared PMM2 CDG patients and controls, and as you can see, the patients have hyperfibrinolysis and the clotting time is prolonged, data that suggests a bleeding tendency. She has also evaluated the thrombin generation, evaluating both the response to the extrinsic pathway and the intrinsic pathway. And as you can see here again, in controls of patients, we have observed significant differences, particularly the lag time, the time that is required to start the coagulation is prolonged in patients. The thrombin that is generated is reduced, and we observe a signal instability. All this data again suggests that this patient could have more risk of bleeding. And again, when we stimulate the thrombin generation by the intrinsic pathway, we observe exactly the same data. Finally, he has already evaluated the clot lysis time, and as you can see here, the clot lysis time is shorter in patients with the congenital disorders of glycosylation, and again, the final result is a higher risk of bleeding. However, and on the other hand, we have also evaluated the main marker of a hypercoagulable state, like the D-dimer levels. And although levels are not extremely high, we consistently observe higher levels of D-dimers in patients than in controls. So what's the final picture we can obtain from all this data? That we have a confused view. I mean, we have several data, like the hyperfibrinolysis, the lower thrombin generation, the prolonged APTT, or the factor 11 deficiency that suggest a higher risk of bleeding, but we also have several data suggesting a high risk of thrombosis, particularly the severe antithrombin and other anticoagulants deficiency. And what happened from a clinical point of view? We still have few data on that. And as you have already said before, we have observed both a high patient with bleeding events, but also with thrombotic events. And maybe we can pull all these manifestations that could be associated with a thrombotic event. And accordingly to our data and also to the paper that has been published, certainly these patients have a higher risk of thrombosis. So now Maria Eugenia is going to show all data that try to sustain the higher risk of thrombosis that this patient have, and particularly what's the mechanism that could explain the higher risk of thrombosis. I would like just to point out that she has been working very hard, and she's still working very hard because we have to answer still to answer this question. So Maria Eugenia.
Thank you. Good morning, everybody. I would like also to thanks to the organization to invite me to be here in this fantastic meeting. And as Javier have already mentioned, we think that this patient has mainly a high risk of thrombosis. And why do we think that? First of all, I'm going to introduce a little bit our group. Our group studies people who have suffered any thrombotic event and who also have antithrombin deficiency, the main anticoagulant that we have also, observed before. And in this context, we recruited last year a very interesting patient from Portugal. This patient, as you can see here, was an 18-year-old boy with 4 severe deep venous thrombosis and two of them under oral anticoagulant therapy and with antithrombin deficiency. We sequenced the SERPINC1 gene, the gene that codes for antithrombin, but we found no mutation in this gene. And after several studies ranging from molecular studies to protein studies, we found that this patient has glycosylation defects in some hemostatic proteins or in some plasma proteins like antithrombin or alpha-1 antitrypsin. And that's why we connected with this disorder, with the congenital disorder of glycosylation. And we started to think about this disease, and we recruited a patient with a PMN2 CDG in order to compare the glycoforms of a PMN2 CDG patient with our proband. And as you can see here, in all the glycoproteins that we have tested, the alpha-1 antitrypsin, the antithrombin, or the transferrin, presented a very similar pattern of glycosylation defects comparing to our proband. So these results lead us to evaluate the PMN2 gene, and we found in our proband 2 different mutations in compound heterozygosity. And this data, together with of course, with the clinical features, lead us to diagnose this patient as a PMN2 CDG. But I would like to remark that we have diagnosed a PMN2 CDG based on the thrombotic complication and on the antithrombin deficiency. So that's why we think that this patient has a very high risk of mainly of thrombosis. Then we started to study further this disease, trying to unravel the mechanism that is involved in the risk of thrombosis in these patients. Because knowing this mechanism, we could develop some treatment or more efficient in these patients. And as you can see, and as you know, in PMN2 CDG, the PMN2 enzyme is impaired, and of course, impairing the N-glycosylation pathway. But on the other hand, there is another pathway that is also involved, that is the biosynthesis of the GPI anchor. That is a lipid that anchors some proteins of the cell membrane. And interestingly, it is known that some different diseases that has a GPI deficiency are associated with thrombotic complications. That's why we, for that reason, and together with the reason that in PMN2 CDG patients, this pathway has never been studied before, we studied the GPI protein expressions in PMN2 CDG patients. So we evaluated by flow cytometry 8 GPI anchor proteins and the GPI itself in 4 different blood cell types of a cohort of 12 PMN2 CDG patients. And as you can see here in these graphs, the PMN2 mutation do not impair the GPI anchor or GPI anchor protein expressions. as you can see here. Maybe, we don't know exactly why, but maybe it's because the requires of the number of mannoses is smaller than the synthesis of the N-glycan precursor. So we can say that PMN2 mutations do not impair the GPA-Antor or GPA-Antor protein expression. And we also performed a specific test that is used in GPI deficient patients and in PMN2 CDG patients. And these tests were negative, indicating that there is no significant, there is no defect in the surface of the erythrocyte as it has in the GPI deficiency pathology. So, in conclusion, we think that there might be other mechanisms involved in the risk of thrombosis of these patients. But I would like now to highlight that this first study with this first approach has also rendered interesting data about the PMN2 CDG disease, and is the following. We have found that the CD16, that is a GPI protein in neutrophils, or a CD14 in monocytes, seems to be reduced in this patient, and we have we have data that suggests that it is because of an impairment in the immunorecognition of some mononuclear antibodies that caused by the abnormal glycosylation of these molecules, the CD16 or CD14, in PMN2 CDG patients. In other words, monocytes and neutrophils of PMN2 CDG patients seems to be affected in the N-glycosylations. So this defect is not restricted to the liver. And maybe, this is an hypothesis, this defect might have functional consequences and could explain the recurrent infections of these patients. But of course, this is an hypothesis that needs to be checked with further studies. And the second positive result that we have that has rendered in this first approach is that our results agree with the suggested stabilization of the glycosylation defects with the age. And now our second approach was focused on the platelets, trying to unravel the mechanisms of the high risk of thrombosis. And some years before, Jagen published a paper in which they said that in patients there is an hyperreactivity, spontaneous hyperreactivity of the platelets of these patients, and with an increased binding of a lectin to these platelets. This lectin binds when there is a glycosylation defects in the platelet membrane. So first of all, we confirmed the increased binding of this lectin in our cohort of patients, suggesting the same, that there is an abnormal glycosylation in the surface of the platelets. Moreover, we studied up to 6 different glycoproteins of the platelets in order to find different glycoforms, different glycosylation defects, as we have found these defects in hepatic and glycoproteins like antithrombin and alpha-1 antitrypsin or transferrins. But as you can see here, none of these N-glycoproteins from the platelets seem to be seems to reveal abnormal glycoforms. And moreover, by flow cytometry analysis, we did not see any significant differences in the expression of the GP of another 2 different glycoproteins, the GP3A or the GP1B alpha. And finally, we have performed a very sensitive methodology that is called a proteomic analysis in order to evaluate all the N-glycoproteins of the platelets. And I have done it in Belgium with a collaboration with Professor Jacken. And this methodology tried to compare all the N-glycoproteins of the platelets in comparing this pattern between a pool of controls and a pool of patients. And again, we saw that there is no N-glycoproteins from the platelets affected. The only N-glycoproteins that were affected with glycosylation defects were from hepatic origin. So all this data suggests that platelets and glycoproteins of PMN2-CDG patients are neither quantitatively nor qualitatively significantly affected. PMN2 mutations have different consequences on diverse cell types, and platelets not been significantly affected, according to our results. And the binding of abnormal glycoforms of hepatic proteins to the platelet surface might explain the increased binding of the lectin in the surface of the platelet and might contribute to explain the moderate spontaneous platelet reactivity described in these patients. But again, we think that this is not enough to explain the so high risk of thrombosis in these patients. So we now are still working hard in another approaches that maybe could have better results. But I would like to remark that any research on CDGs will give new information for this rare disease. This disease is very complex, but any step that we are in a study revealed new information, and we are little by little getting to know better this disease. Like this one, the GPI anchors pathway is not affected, that glycosylation defect seems to be tissue-specific, and that seems to be a kind of stabilization of the glycosylation defects with the age. And concerning to the hemostatic system in these patients, we could say that these patients have significantly impaired the hemostatic system that increases the risk of bleeding, but particularly of thrombosis, that the mechanism is still involved in this increased risk of thrombosis is still unknown, and that unfortunately there are neither any clear hemostatic marker of high risk of thrombosis and nor specific treatment. So we also could say some suggestions in the hemostatic system of PMN2-CDG that are only suggestions, because these studies are now unpublished and we need more studies. But we could suggest that, first of all, that any form of tissue damage, immobilization, and probably fever and hormone treatment could be risk factors for developing thrombotic events. So if it's possible, we suggest to avoid elective surgery or other invasive techniques as well as hormone treatment, and encourage active in even passive physical therapy and antithermic procedures. And also, if it's possible, of course, we also suggest to avoid the use of anticoagulant or antiplatelet treatments in these patients. And now I would like to show you our group. This is the hemostasia and thrombosis unit, and the ones that are highlight are the ones that are working directly with this disease. And of course, I would like to acknowledge, first of all, Professor Jacken for all his always kind collaboration and his always clever suggestions. All the people that are in collaboration with us from many places all over the world. And of course, we are in debt with all the patients and with mainly with their families, because of their great and always generous collaboration with us. And thank you very much.